Hello, my name is Adam Briggs, and I'm an assistant professor of psychology at Eastern Michigan University. Prior to arriving at EMU, I spent more than 10 years working in clinical settings with individuals who engage in severe destructive behavior, including a 2-year postdoctoral research fellowship at the University of Nebraska Medical Center's Monroe-Meyer Institute under the mentorship of Dr. Wayne Fisher. I've conducted research in the area of assessment and treatment of severe behavior disorders, including several grant-funded research projects focused on integrating stimulus control technology and consequent-based refinements in ways that mitigate relapse and improve the efficacy and generality of functional communication training. Today, I'll be discussing the outcomes of these and other related projects with you and describing how you can incorporate these evidence-based procedural advances into your practice tomorrow to promote durable treatment outcomes. But before we get into all that, I believe that in order for you to appreciate where we are as a field today and to understand the direction we're currently heading in, it's very important to remember where we have been, because it's incredible how much progress we've made in a relatively short amount of time. In general, I see our field having gone through 3 phases. Before phase 1, the predominant thought in terms of treating severe behavior disorders was basically in either one of 2 camps. First, it was either part of your medical diagnosis that caused you to engage in severe problem behavior, or the alternative theory was that you were engaging in problem behavior to punish yourself out of feelings of guilt. And as you can imagine, neither of these approaches gives us a whole lot to work with in terms of how to treat these individuals. So phase 1 began in the 1950s and 60s when behavioral scientists began extending the principles of behavior analysis that were first developed and validated in laboratory settings and translated them into technology to address socially significant clinical problems. For example, in 1959, Ted Ione and Jack Michael reported on successfully reducing persistent problem behavior of psychiatric patients that included psychotic talk, hoarding, and refusal to self-feed by training hospital personnel to use operant procedures such as reinforcement and extinction. And in 1964, Mont Wolf, Todd Risley, and Hayden Meese reported on successfully reducing temper tantrums, bedtime and mealtime problems, and eyeglass throwing of a child named Dickie by increasing appropriate verbal behavior, shaping his wearing of the glasses, and training his parents to apply the procedures using those same behavioral principles. Their approach toward treating behavioral disorders was markedly different from the typical medical model that dominated American abnormal psychology at that time. That is, behavioral scientists believe the abnormality is not a problem within the individual, but rather is the result of the person's interaction with his or her social environment and represents an understandable outcome of the individual's history of reinforcement. There were a number of other applications that came out over the next 10 to 15 years, primarily published in the Journal of Applied Behavior Analysis, that make up phase 1 of our understanding, that the consequences produced by the behavior are likely the reason why severe problem behaviors are shaped up and maintained in these environments. That's also when we got involved in treatment approaches for behavior disorders. Treatment at this time was characterized by 2 primary approaches, either a trial and error approach, that is, let's see if this works and so awesome, but if not, let's just try something different, or applying really strong contingencies of reinforcement and especially punishment. That is, let's identify a powerful arbitrary reinforcer or a synthesized reinforcer, arrange some DRO or DRI contingency, and if those were not effective, then we would rely heavily on punishing behavior. So relatively soon after this period, there were 2 key events that happened which shifted us away from these approaches, and we transitioned into phase 2. The first event was Ted Carr's 1977 publication, a review paper that summarized all the available literature to identify any explanations for the occurrence of severe problem behavior. Basically, what he said was, it's not necessarily a medical problem, there's no evidence for psychodynamic explanations, but there is evidence for operant explanations, that behaviors produce an environmental effect, and it's those environmental effects that are causing those problem behaviors to continue to happen. This was a real big deal, and it resulted in a paradigm shift in thinking. What that ultimately led to was Brian Iwata's 1982 publication of the first comprehensive functional analysis methodology, or a pre-treatment way to identify what these reinforcers are in the environment that are maintaining the behavior. Understanding the function of problem behavior allowed us to accurately identify what treatments were more likely to be effective, what treatments were less likely to be effective and even might make things worse, and greatly reduced our reliance on punishment. And again, this is a really, really big deal. One of the earliest function-based interventions was published in 1985, which was Carr Durand's seminal paper on functional communication training, which is the topic of today's presentation. Although there have been hundreds of publications and replications showing that these approaches are extremely efficacious, it's important to recognize the context in which most of this research has been conducted. That is, the vast majority of studies that make up what we know of FCT are typically conducted in small, sterile, padded rooms where you can control most of the environment. Further, most of them have been conducted at specialized treatment facilities like the Kennedy Krieger Institute, Marcus Autism Center, or the Monroe Meyer Institute. Typically, the interventionists in these settings are highly trained staff who reinforce a relatively simple alternative response on a dense schedule of reinforcement and have a team of doctoral level behavior analysts immediately available to problem solve if things begin to break down. Let me be clear though, this is not a criticism, this is good science. In these settings, researchers are attempting to control as many variables as possible so they can identify the precise role of these interventions. And they work great. But they're effective under highly controlled environmental conditions, and we all know that is not the real world. So where I think we are now is this transition into phase 3. And it is this transition out of these environments, and it's based on the understanding that perfect implementation is like, well, the Detroit Lions winning the Super Bowl, that it's unlikely to happen. And I can make that joke because I'm a lifelong Lions fan. But recently, there have been a number of studies that intentionally identify mistakes that families are likely to make when we ask them to start implementing these treatments. Not because they're lazy or non-compliant or not well trained, but simply because they're humans who have many competing contingencies that must be attended to while in the home, which likely interfere with their ability to implement an effortful, complex, and involved protocol with high integrity. Again, this is not a criticism, but it's a reality that researchers and clinicians must understand if we're going to develop an effective intervention with sustainable therapeutic outcomes. Moreover, there is a need for identifying treatment challenges one might experience and to understand what happens when caregivers do encounter them. And what we've learned is that treatments fall apart and problem behavior comes surging back stronger than before. We call this treatment relapse, and it's discouraging for everyone. Unfortunately, relapse typically results in the client being readmitted to receive more intensive services focused on behavior reduction, which becomes a barrier to working on other adaptive skill acquisition programming. Therefore, we must continue to develop more durable interventions that caregivers are able to implement consistently. So one thing I do love about our field is that we, as scientists, have this efficacious, highly demonstrated treatment, but we're not running around the world yet advertising that everyone needs to start doing this because we're still busy identifying every procedural flaw and potential challenge that could possibly happen before we're confident and comfortable marketing it. And it's one of the things that I'm most proud of is that we're dedicated in solving and identifying problems before our interventions go to market. That is, we're going to break it every which way possible and put it back together so that it's stronger than it was before. This is analogous to the Japanese art and philosophy of kintsugi, which is repairing broken pottery by mending the areas of breakage with lacquer mixed with powdered gold. As a philosophy, it treats breakage and repair as part of the history of an object rather than something to disguise. Similarly, the evolution of behavioral intervention in our field is important and deserves to be highlighted so we value the process and can anticipate further progress. Over the past 30 years, FCT has been broken down and put back together many, many times. As a result, we've made procedural refinements to help mitigate relapse and promote durable treatment outcomes. So the purpose of today's presentation is to orient you to FCT and spend the majority of the time reviewing how you can incorporate these procedural advancements into your practice. First, I will provide an overview of FCT and summarize these procedures, spending time to review some important terms I will use throughout the presentation. Second, I will identify reasons why FCT might break down and will provide a review of the common forms of treatment relapse. Third, I will review recent advances in FCT research, describing procedural refinements that help to prevent and mitigate these forms of relapse and aid in its overall durability. Fourth, I will discuss some current and future directions for research in this area. And finally, I will wrap up by suggesting strategies for staying informed of the latest procedural advancements in FCT. But before we get started, I want to review some important terms and concepts I'll be using throughout today's presentation. As most of you know, FCT is a differential reinforcement of alternative behavior procedure in which the appropriate alternative behavior is a functional communication response, or FCR. And target behavior is the maladaptive problem behavior, which is typically placed on extinction. During today's presentation, we will also be discussing the conditions under which treatments fail and problem behavior comes back. In general, we refer to this as relapse, or the failure of treatment gains to be maintained when treatment conditions change. Specifically, there are 4 common types of relapse we will review today. Those are extinction burst, resurgence, renewal, and reinstatement. As mentioned, each of these unique phenomena are considered a form of treatment relapse and threaten the durability of one's intervention. I will define each of these forms of relapse and discuss procedures for preventing or mitigating their impact after we review FCT. So, as we all know, FCT is a well-established treatment for socially mediated problem behavior exhibited by children diagnosed with autism. The efficacy of FCT greatly relies on the precise results of a functional analysis to indicate the function for the occurrence and maintenance of problem behavior. In general, FCT involves the delivery of the reinforcer responsible for the maintenance of problem behavior contingent on a functionally equivalent communication response. Commonly, children with delayed communicative repertoires learn to engage in other forms of behavior to get access to their preferred items. For instance, we often see children who learn that they can engage in aggression to gain access to their iPad. Using FCT, we would train an FCR, in this case a card exchange, as an appropriate alternative response to access the preferred items. Specifically, this procedure would provide the functional reinforcer, in this case a tablet, only for the appropriate alternative response. Meanwhile, all instances of problem behavior would be placed on extinction, meaning they would cease to result in access to the reinforcer. In a recent summary of the effects of FCT during schedule thinning, Greer and colleagues observed that FCT, when combined with extinction, reduced destructive behavior by an average of 96% relative to baseline levels. Although FCT is effective and seems like a pretty straightforward intervention, as many of you can attest, there are many important and nuanced aspects of FCT procedures that need to be considered when one is selecting and implementing the initial teaching procedures, thinning the schedule of reinforcement for the FCR, transitioning the effects of the intervention to the client's everyday environment and primary caregivers, and responding to instances of problem behavior during situations when it cannot be ignored. Determining how you're going to execute each aspect of FCT is critical because if done incorrectly or haphazardly, each one is associated with evoking a form of relapse. That is, if the initial teaching procedures are implemented imprecisely or without good integrity, there's a risk of evoking an extinction burst of problem behavior. If the schedule of reinforcement is thinned too quickly or without warning, a resurgence of problem behavior might occur. If the transition to the everyday environment happens without proper planning, renewal of problem behavior is likely to be observed. And if the problem behavior occurs at a high rate or magnitude and cannot be ignored due to its severity, then response-dependent reinstatement is likely to occur. Next, we'll discuss each of these types of relapse in more detail. Treatment relapse is a generic reference commonly used in medical and mental health fields to describe the emergence of some condition that was previously treated successfully. And as mentioned, it is well documented that FCT has shown to fail following initial success. Relapse during FCT could be conceptualized as the failure to generalize treatment effects across time, setting, situations, or individuals. Treatment relapse remains a serious concern because it's likely to lead to a sequence of unfortunate events. That is, when problem behavior reemerges, no matter the reason, it puts the caregiver in a situation they are typically not well prepared to manage, which makes caregivers feel overwhelmed and discouraged. As a result, Caregivers are likely to reinforce instances of problem behavior on an intermittent basis, thus strengthening it and producing increased levels of dangerous problem behavior. As problem behavior worsens and becomes unmanageable for the caregiver, all progress in other skill acquisition programming is halted or slowed down, thus producing a barrier to other learning opportunities, and the client is likely to be referred to receive more intensive behavioral intervention. These intrusive and oftentimes restrictive forms of intervention directly impact the client's quality of life. It presents logistical and financial strains on the family and increases the overall levels of stress experienced by the family. So next, we'll review the 4 types of treatment relapse that practitioners are likely to experience. Now, it's possible that most relapse cases that occur with humans in clinical situations more closely resemble combined relapse, wherein context and contingencies of DRA interact, increasing the overall magnitude of relapse. However, for the purpose of today's presentation, I will review each of these specific forms of relapse more closely, and then we will review methods for mitigating their effects. So first, we'll look at the extinction burst. Simply put, when a previously reinforced response no longer pays off, that response will temporarily increase in the frequency, duration, or magnitude. Although likely most familiar to you, it is actually one of the least common phenomenon, especially when reinforcement is available for an alternative response. An everyday example of this might be when you insert money into a vending machine and press that big shiny button displaying your favorite ice cold beverage like you've done 100 times before, and nothing comes out. You're likely going to press that button a few more times before trying some other functionally related, like shaking or banging responses in order to get your beverage. Similarly, just recently, the battery on our TV remote recently died on us, and I had difficulty with turning on the TV. So I stood there smashing the power button repeatedly for a good 30 seconds before realizing it was all out of juice. So in summary, this is an adaptive response pattern that is often shaped up, strengthened, and maintained by intermittent reinforcement. I mean, think about it. One should never quickly bail on a previously reinforced response. Sometimes accessing reinforcement requires a little bit of persistence, and we learn the value in this response pattern. So as you are likely already thinking, the same pattern of responding often occurs with our clients. Specifically, during some initial FCT sessions where we are placing the problem behavior on extinction and only providing the functional reinforcer for the FCR, we might see the client test out that problem behavior a couple more times before learning that it no longer pays off. Old habits can be challenging to break. Similarly, once we've actually taught the client to engage in the FCR, it's often necessary to thin that schedule of reinforcement. And during this time, the FCR itself might contact brief periods of extinction, which oftentimes produces repetition of requests. Next, we will review the concept of resurgence. Similar to the extinction burst, resurgence is a transient or temporary phenomenon. However, it differs in that it's the recurrence of a previously suppressed response when reinforcement for the other response no longer pays off. This phenomenon is very prevalent, as it has been demonstrated to occur in 76% of cases when thinning reinforcement during FCT. An example of this comes from an experience I had pre-COVID with my students. That is, as much as I love being available to meet with my students, I noticed that when they would pop in for visits during my scheduled work times, it was really disruptive to my workflow and overall productivity. Therefore, I put a rule in place. No more pop-ins outside of my regular office hours, and that they must send me an email to set up a meeting. And this worked great. Students began emailing me almost to the point where it was sometimes difficult to keep up. And I noticed that if I was not quick to respond and reinforce their appropriate alternative response, which was emailing me, that I would soon see them engage in the old previously reinforced response of popping in to get their questions answered. So like an extinction burst, this too is an adaptive response, in that if one response doesn't pay off, you're going to go back to the one that previously did pay off. The same thing happens with our clients. When we teach them a new response to get access to the preferred items, but are either not able to respond immediately, or we're purposefully teaching them that sometimes your requests don't pay off, we run the risk of the old, previously reinforced response resurging back. Given how prevalent this phenomenon is, we need to expect that it will happen, and we must have strategies in place to either mitigate its impact or prevent it from happening entirely. Similar to resurgence, renewal is the recurrence of a previously eliminated response. However, it differs in that the response is simply evoked based on changing of the context to one in which the former response was previously reinforced. Although not as prevalent as resurgence, recent studies have shown that it still occurs in more than half the cases about half the time. So an everyday example of this might be when you visit with your parents in the home that you grew up in. You have a very rich and lengthy reinforcement history in this context, and you might find that you speak or engage in behavior that you had not done so since your high school years, both good and bad. Maybe you use more slang, or maybe you're used to not having to do the chores or help with the dishes, even though you do that all the time in your own home. So engaging in behavior that had previously been reinforced in this old setting is the product of stimulus control. And once again, this ability to discriminate between different patterns of behavior based on the context is an important one for us to learn. For example, growing up, I learned to interact very differently with teachers in the classroom as compared to my friends after school or on the playground. Different behaviors are reinforced, extinguished, or punished in some contexts, like classroom with teachers, as compared to other contexts, like playground with friends. And we learn to discriminate these differences, and our behavior matches up with these consequences. The same thing happens with our clients too. When they come to the clinic to learn skills and contact certain behavior management contingencies, they learn to behave differently in this setting, especially if those same contingencies are not in place in home with the caregivers. So when we achieve treatment effects in the clinic, we should not expect these effects to automatically transfer to the home or the school setting with the caregiver or teacher. Programming for this is a critical piece of this intervention. So last but not least, reinstatement is another common form of relapse that occurs when the presentation of reinforcer maintaining responding prior to extinction is presented response independently or dependently, and the extinguished responding reappears. Although there are currently no prevalence estimates of this phenomenon within the clinical setting, it has been demonstrated in several studies with individuals diagnosed with intellectual and developmental disabilities who engage in severe problem behavior. An everyday example of this might be when one is dieting and attempting to abstain from unhealthy treats. The sight, thought, or taste of just one can produce additional treat-seeking behavior. A silly example of this is a classic sketch from Saturday Night Live during the mid-90s with my favorite Chris Farley playing a Gap girl alongside his pals David Spade and Adam Sandler. During the scene, Chris Farley's character expresses hunger and samples a single French fry off the plate of one of the other characters. And before we know it, Chris Farley's character is shoveling fries into their mouth. One of the other characters says, "I thought you were on a diet," to which Chris Farley responds, "Lay off me, I'm starving." Again, this is an example of just tasting that simple fry is going to produce much more behavior in that direction. So as you might expect, this phenomenon can also occur with our clients when the reinforcer is made freely available and sampled by the individual. They may begin to engage in the previously extinguished response to continue accessing it. Or more commonly, if the individual engages in a target response and the environment inadvertently reinforces it through an error of commission, this contingency can result in the rapid reacquisition of the previously extinguished response. Given this, there is need for ensuring procedural fidelity or having a strategy for instances of the target behavior that cannot be ignored. Next, for each form of relapse we just discussed, I will review the recent procedural refinements that have been demonstrated to help prevent or mitigate relapse and promote durable treatment outcomes. To prevent or mitigate relapse in the form of an extinction burst, it is critical to select the initial teaching procedures very carefully. In general, there are several important procedural characteristics to consider prior to and during FCT. Specifically, one will want to carefully consider selecting the FCR, programming errorless learning procedures, and arranging a dense schedule of reinforcement to avoid the possibility of generating an extinction burst. First, I will review considerations for selecting the FCR. An FCR can take a variety of forms. That is, the functional communication response can be vocalizations, cards containing words and or pictures of the item and activity, signs or gestures, communication boards, or vocal output systems, just to name a few. Although there is a variety of options to choose from, there are three important features one must consider when deciding between the form of the FCR. First, especially when starting out, it's critical to select an FCR that can be prompted. Initial teaching relies on the FCR contacting that reinforcer consistently and immediately. For instance, if the initial FCR is a vocal response, it might be very difficult to prompt somebody to engage in this, which will result in a delayed reinforcement that will then increase the exposure to the relevant establishing operation that might evoke an extinction burst. Therefore, it's recommended to choose a response that can easily be prompted, like a picture touch or a card exchange, to initially teach the relation prior to then increasing the complexity of the FCR later down the line. Next, because you're trying to replace the maladaptive problem behavior with a more appropriate alternative response, it is important to make sure the FCR requires relatively less effort than the problem behavior to increase the likelihood that the client will choose to engage in the FCR over the problem behavior. Once the individual is efficient with the FCR, then it's recommended to systematically increase the complexity or effort of the response. Last but not least, it's important that an FCR is selected that will be recognizable by the individual's verbal community so that it will be reinforced and not placed on extinction. For instance, if you decide to teach your client sign language, it's critical that the client's caregivers and school personnel are fluent so they can adequately respond to your client's demands quickly and reliably. So next, I'll discuss the importance of initially teaching the FCR using errorless learning. The purpose of errorless learning is to ensure that teaching conditions are implemented with perfection. That is, the relevant antecedent and EO are present to teach the FCR, the individual is prompted immediately to engage in the FCR, and the FCR results in the functional reinforcer immediately and reliably. Specifically, errorless training procedures are just another name for most of these prompting. In this arrangement, as soon as the reinforcer is removed, in this case an iPad, there is a 0-second delay to the therapist providing a full physical prompt. Following success at this 0-second delay, the therapist will continue trials with a 2-second delay before providing the prompt. And so on, until the individual is consistently engaging in the FCR independently. It's at this point where a therapist might consider increasing the complexity of the FCR in order to gradually produce that end goal. By conducting those initial teaching trials in this fashion, you will decrease the likelihood of an erroneous antecedent or EO influencing the response, prevent delays to the FCR, and eliminate the possibility of the FCR contacting delayed reinforcement or even extinction. Next, I will discuss the importance of initially reinforcing the FCR immediately and on a dense schedule of reinforcement so as to avoid an extinction burst. During initial training sessions, it is crucial to deliver the requested reinforcer on a continuous schedule to strengthen the response and avoid it contacting extinction during this stage. A continuous rate of reinforcement looks exactly how it sounds. Each time the individual requests using the FCR, they get the item requested. Again, the reason this is important during the initial training of the FCR is because if an instance does not pay off, you might see a burst of responding and problem behaviors like to reemerge if the delay is lengthy enough. Speaking of delayed reinforcer, not only is it important to deliver the reinforcer continuously, but it's just as important to deliver it immediately following the FCR. The longer the delay following the FCR, the greater the establishing operation will build for that item, increasing the risk of other functionally related problem behavior emerging before the reinforcer is delivered. Therefore, delayed delivery following the FCR is less than ideal and should be avoided to reduce the risk of problem behavior reemerging. Instead, it's recommended that the delay to the reinforcer is very minimal and that it can be delivered as immediately as possible following the FCR. Making immediacy a priority will serve to strengthen the response more quickly during the initial teaching phase and will reduce the risk of treatment relapse.
Next, you will watch a brief clinical simulation that demonstrates the initial FCR teaching procedures. Specifically, the therapist will train a simple FCR, in this case a cart touch, because it can be easily prompted. You will see the therapist present the relevant establishing operation to teach the man, in this case removal of the iPad, and the therapist will provide a physical prompt for the client to engage in the FCR, and then the therapist will immediately provide access to the iPad. Following several consecutive responses at a given prompt level, the therapist will fade the prompt level until the client engages in an independent FCR. Throughout this process, if any problem behavior does occur, the therapist will block and ignore these instances.
Give it to me. Good job touching the card. Give it to me. Good job touching the card. Give it to me. Good job touching the card. Give it to me. Nice job touching the card, Katie. My turn. Nice work touching the card. My turn to play. Good job touching the card, Katie. My turn to play. Nice work touching the card. My turn to play. Good job touching the card. My turn to play. Good job touching the card. My turn. Nice work touching the card. My turn. Good job touching the card, Katie.
To prevent or mitigate relapse in the form of resurgence, it's recommended that clinicians use compound schedules with discriminative stimuli during schedule thinning. Following an effective SCT evaluation, behavior analysts typically begin programming for reinforcement schedule thinning and commonly use other multiple schedules or chain schedules to accomplish this. Specifically, multiple schedules involve a time-based alternation between intervals of extinction and reinforcement for engaging in the functional communication response. These intervals are signaled by schedule-correlated stimuli to bring the response under stimulus control, and the schedule of reinforcement is then thinned by extending the extinction interval until a practical schedule is reached. A chain schedule is similar to a multiple schedule, except rather than time-based alternations, a work requirement is presented during the extinction interval. When the work requirement is completed, the reinforcement interval is initiated. As in the multiple schedule, the reinforcement and extinction intervals are signaled by schedule-correlated stimuli, and the schedule of reinforcement is thinned by increasing the work requirement until a practical schedule is reached.
Next, you will watch a brief clinical simulation that demonstrates bringing in an FCR under the stimulus control of the multiple schedule. That is, we are teaching the client that although the FCR remains available throughout the entire session, it is only effective during the S+ or the green card condition and will not result in reinforcement under the S- or the red card condition. In general, this discrimination training procedure is set up to reinforce the waiting behavior with the presentation of the S+, and once stimulus control is established, you can gradually increase the length of the S-, or the time the client must wait prior to getting access to the S+ period, where their FCRs will then be reinforced.
Nice touching the card, Katie. Nice touching the card. waiting. Nice job touching the card.
The primary benefit of using discriminative stimuli when fitting schedules of reinforcement during FCT is that research has demonstrated that establishing tight stimulus control over responding in treatment with these condition signaling stimuli mitigated resurgence as compared to interventions that did not use them. In addition, research has also shown that once discriminative control is established, these stimuli can then be used to facilitate rapid reinforcement schedule thinning. That is, going from waiting 30 seconds to jumping to 4 minutes, or completing a handful of demands to completing 20 or 30 demands, instead of progressing along this slow and systematic increase. Further, research has also shown that once discriminative control is established, these stimuli can then be used to facilitate rapid transfer of treatment effects from the behavioral technician to the caregiver, thus prompting generalization of treatment effects and decreasing the likelihood of relapse related to contextual changes, which more on this next. So to prevent or mitigate relapse in the form of renewal, it is recommended that clinicians program for generalization. In order to prevent or mitigate renewal during transitions to the client's everyday environment, one needs to look no further than our field's work in programming for generalization, starting with the seminal article by Stokes and Bear in 1977. Since then, researchers have extended this technology to FCT and have suggested strategies for accomplishing this, including programming common stimuli and training sufficient exemplars. In more recent reviews of the emerging renewal literature, researchers have suggested renewal mitigation strategies that align with techniques for programming for generalization. However, there's a paucity of research demonstrating renewal mitigation with humans. Many strategies for mitigating renewal described in the non-human animal studies are consistent with generalization techniques used by clinical behavior analysts, such as systematically increasing the similarity between the context in which maladaptive behavior occurs and the context in which it is treated. For example, having natural behavior change agents implement treatments alongside therapists as part of a clinic-based intervention, which is referred to as context fading in the renewal literature, and incorporating common mediators in the applied literature. Next, establishing discriminative control over appropriate behavior using treatment-correlated stimuli and introducing those stimuli to novel contexts, referred to as extinction cues in the renewal literature and as programming common stimuli in the applied literature. And successively introducing the treatment to multiple contexts prior to the target context, referred to as multiple context training in the renewal literature and training sufficient exemplars in the applied literature. However, only one study has attempted to mitigate renewal with humans of a socially significant dependent variable in an applied investigation. Next, we will discuss how these investigators incorporated common mediators to promote generalization of treatment effects and mitigate renewal. Specifically, Kelly and colleagues used a context fading procedure to successfully mitigate ABA renewal in 3 children diagnosed with autism. In general, the procedure incorporated generalization stimuli that included pairing implementers and introducing the therapist into the training context. As an example, Jules' baseline occurred in context A. In this case, it was at home with mom, in which problem behavior was reinforced. Next, intervention, in this case, escape extinction, occurred in the clinic with the therapist. Following an effective intervention in context B, they returned to context A. However, this time the mom was trained to implement the intervention. And as you can see, problem behavior continued to occur at rates similar to baseline. Next, they returned to the previously effective intervention in context B with the therapist in the clinic and immediately recaptured treatment effects. For the renewal mitigation technique, stimuli from context A and B were combined in that the therapist conducted the session with mom present and the treatment effects continued. Finally, they returned back to context A with mom now conducting the intervention, and it appears that simply pairing mom during the intervention sessions with the therapist was effective at transferring control, mitigating renewal, and promoting maintained treatment effects. So results suggest that maintaining common elements from the extinction context, that is, the therapist in a clinical setting, and pairing them with those from context A, parent in the home setting, could underlie an approach to mitigating renewal of problem behavior during clinical interventions. This is an important finding because settings such as school or home often serve as context A for inadvertent clinical renewal arrangements when students obtain therapy in a clinic. Therefore, understanding the role of context changes in the relapse of problem behavior and incorporating these potential mitigation strategies can inform clinical interventions and help to prevent relapse. So to help you understand how each of these approaches works toward programming generalization and how that can be accomplished as a renewal mitigation strategy, I will walk through some of the brief examples of this showing visuals. So first, we will review a strategy employed by Kelly and colleagues, that is the context fading. So here, the therapist works with the client and establishes treatment effects in their presence. Next, the caregiver joins in on these sessions to promote transfer of treatment effects, thus increasing the likelihood that once the parent implementing is faded out, treatment effects are more likely to maintain and renewal is likely to be mitigated. Next, another method is to program common stimuli to enhance the transfer of treatment effects. In this case, the therapist uses discriminative stimuli, and once stimulus control is established, these stimuli can then be transferred across environments and other caregivers to promote maintenance and mitigate renewal effects. Last but not least, another method is to train sufficient exemplars to enhance the transfer of treatment effects across contexts. For instance, the therapist would conduct sessions in the home environment, the clinical setting, and the school setting in an attempt to teach the client that no matter what setting or context, this intervention is in effect everywhere, such that when other novel settings are introduced, there is a greater likelihood that treatment effects will maintain and renewal will be mitigated. So to prevent or mitigate relapse in the form of reinstatement, it's recommended that clinicians consider arranging contingencies so that reinforcement favors the alternative response more than the target response in cases where extinction cannot be used for the target response. So although extinction is often a critical component of DRA treatment package, potential side effects of extinction may lead to dangerous levels of destructive behavior and comprise levels of treatment integrity and may not be a feasible option for certain individuals in certain environments. Previous research has shown that manipulating the dimensions of reinforcement, such as magnitude and quality, to favor an alternative response over problem behavior effectively increases the alternative response, even when problem behavior continues to produce the functional reinforcer. Taking it back to original FCT example, engaging in problem behavior would now result in access to the reinforcer for a short period of time, let's say 30 seconds. However, the appropriate alternative response would result in access to the reinforcer for an extended period of time. This would be a reinforcement magnitude manipulation with their favorite snack and preferred therapist attention. This would all be a quality manipulation. So under these circumstances, it's all about minimizing the amount of reinforcement provided for the problem behavior and maximizing the amount of reinforcement available for engaging in the appropriate alternative response. Results provide further evidence of the efficacy of alternative strategies for treating severe destructive behavior when extinction might not be a feasible option. That is, manipulating dimensions of reinforcement to favor alternative response, for example, the FCR, even when the target response, that is the problem behavior, continues to produce the functional reinforcer. Further, this approach will likely prevent further escalation of problem behavior while also teaching the individual that if they want to maximize their reinforcement, they should allocate their responding to the response option that produces a higher magnitude and higher quality reinforcement period. Finally, this approach could potentially mitigate risk of reinstatement and rapid reacquisition, given motivation for engaging in the alternative response should remain high, thus decreasing likelihood of relapse. To summarize, although FCT has been demonstrated to be an effective intervention, there are a number of important procedural aspects of FCT that need to be carefully considered and planned for in order to mitigate or prevent various forms of treatment relapse. Today, we reviewed several evidence-based strategies that have been shown to mitigate or prevent specific types of relapse. Although we've come a long way, there remains gaps in this research literature that still need to be addressed. In addition, there are other procedural strategies published in the literature that may also serve to mitigate relapse and promote treatment durability. However, they have not yet been evaluated under these circumstances. Therefore, next I'll discuss some current and future directions for research that should be considered. Although I've presented a number of potential strategies one might employ to mitigate or prevent various forms of relapse, none of these represent a clear solution for treatment relapse. Therefore, a need to explore other strategies for mitigating relapse and promoting durable treatment outcomes remains. For instance, one might consider providing access to alternative activities during the S-delta or extinction component of compound schedules to offer something else to do while the clients are required to wait to access the preferred item. Another strategy might be to teach an individual to engage in multiple alternative FCRs so that when one contacts extinction, instead of jumping right to problem behavior, they might try to engage in another appropriate communicative response. Another commonly used procedure that could also be a potential strategy for mitigating relapse is delayed denial tolerance training. Although relapse has been observed and is prevalent in these cases, it could be that these procedures might benefit from using discriminative stimuli to help signal periods of delay, denial, and enhance the tolerance training program. Next, quantitative theories of relapse have sparked targeted research lines, both in terms of uncovering the processes that give rise to relapse, as well as studies examining how to mitigate and prevent it. Specifically, studies based on behavioral momentum theory have demonstrated that relative reinforcement and extinction histories for target and alternative behavior affect relapse. In addition, resurgence as choice theory suggests that decreasing relative response effort and increasing bias for the alternative response, incorporating extinction for problem behavior and arranging smaller steps when schedule thinning, and decreasing motivation for the functional reinforcer are all potential strategies for mitigating or preventing relapse. However, most of these theories and predictions still need to be investigated in either translational or clinical evaluations to determine whether or not they might offer further recommendations when planning for and implementing FCT to mitigate or prevent relapse and promote durable treatment outcomes. So, as you can see, although we've made tremendous progress toward the development of FCT procedures that mitigate relapse and promote durable treatment outcomes, it's also obvious that we still have a ways to go before reaching a behavioral inoculation for treatment relapse. We need to continue breaking FCT every which way and putting it back together until it becomes a durable intervention, immune to threats of relapse, that caregivers are able to consistently implement. So you might be asking, Dr. Briggs, how many breaks does it take? Yes, I realize I might be dating myself with this reference, but the answer is I don't know. But I do know that researchers continue to break FCT and are publishing their improvements on a regular basis. Therefore, I strongly recommend that practitioners develop some strategies for staying informed of the latest procedural advancements. As previously mentioned, the FCT research literature is rapidly evolving, and it's important to adopt methods for staying in contact with the scholarly literature. In general, practitioners would be wise to secure access to a searchable database for when they need to look something up, determine methods for accessing journal content, such as subscribing to pertinent journals, and arrange strategies for contacting the recently published research, such as signing up for table of content alerts, organizing journal clubs to talk about new research, listening to behavior analytic podcasts, and attending conference workshops and presentations just like this one. So to summarize all that we've discussed today, although FCT is a well-established treatment for socially mediated problem behavior, it is not immune to treatment relapse. However, results of recent research indicates several relapse mitigation strategies that practitioners can incorporate into their practice today. Our understanding of relapse and its technology for mitigating its effects is rapidly evolving, and practitioners are advised to develop strategies for staying in contact with the literature in this area to inform their practice. So now for some parting thoughts. I think it's good every now and again to stop and remember the humanity of the people of who we're working with. That every single one of those data sets is a family in crisis. Every single one of those sets represents a parent who can't sleep because they're worrying about their children or what their child's future is going to hold. And the work that you all are doing is making a really big difference. The truth be told, there are not a lot of us. In fact, there are a lot more families that need help than there are people to provide that, like us. So thank you for the services that you're providing. And as a clinician, thank you for making me better and a more thoughtful and caring researcher. And I truly hope that you found something today within the presentation that you'll be able to take and use to improve your practice. So if you have any questions or would like to request slides, please feel free to email me and I'll be happy to help. Thank you very much.